Bismillah ar-Rahman ar-Rahim. Today I'm going to give a lecture about postpartum hemorrhage. I'm Dr. Manal Hamdy, Professor of Obstetrics and Gynecology, Cairo University. I have this important diagram about the postpartum hemorrhage, that it's the leading cause of maternal mortality worldwide, and you should be prepared and identify source quickly. And we have several causes. The 70 to 80% is the uterine atony, failure of uterine contraction, and the 10 to 20% is cervical laceration and vaginal laceration. We have to know the risk factors, and we have to know how to proceed for each cause. For example, the risk factor for uterine atony, you can find infection, prolonged labor, multipara, if there is retained placenta or multifetal gestation, if the mother has polyhydramnios, macrosomia, and coagulopathy. The uterine atony, it responds to medication. First, we can do pressure, whether external or clot evacuation and internal massage. We will talk in detail. Or we give uterotonic medication like the Oxytocin, the ergonovine, the prostaglandin, the misoprostol, plus or minus the tranexamic acid. You can do a tamponade, whether with a Foley's catheter or what's called Bakri balloon. I will talk about it later. And if these measures do not control the bleeding, you call a specialist. This patient may need DNC, hysterectomy, uterine artery ligation, or embolization. For the risk factor of the cervical laceration, for example, those having a perceptive labor, a large baby, pushing past incompletely dilated cervix, or uncontrolled descent. It will respond, of course, to suturing, whether the vaginal or the perineal laceration, again suturing. The cervical laceration, you do approximation of the edge of the lacerated cervix with ring forceps. This is a very important diagram. Then the postpartum hemorrhage, as I told you, is the leading cause of maternal mortality. It's responsible for nearly 34% of all maternal deaths. And we have to know that resuscitation and management of the obstetric hemorrhage, plus identification and management of the underlying cause. You should remember that there should be successful management of postpartum hemorrhage. It requires both components should be simultaneously and systematically addressed. So all women who carry a pregnancy beyond 20 weeks of gestation, they are at risk of postpartum hemorrhage and its sequelae. In the industrialized countries, the postpartum hemorrhage ranks in the top 3 causes of maternal mortality, along with embolism and hypertension. In the developing world, the maternal mortality rate in excess of 1,000 women per 100,000 live births, and the WHO statistics suggest that 60% of those deaths due to postpartum hemorrhage, more than 100,000 maternal deaths per year. Or the American College of Obstetricians and Gynecologists place the estimate at 140,000 maternal deaths per year, or 1 every 4 minutes. Too much of. And the definition is sometimes or somewhat problematic. We can define it as blood loss of more than 500 milliliter following the vaginal delivery, or more than 1 liter following the cesarean delivery. The loss of this amount within the first 24 hours after delivery, we call it early or primary postpartum hemorrhage. If it is more than 24 hours after delivery, we call it late postpartum hemorrhage. Then, why the estimate of blood loss are subjective and generally inaccurate? Because actually the caregivers consistently underestimate the actual blood loss. If there is 10% fall in the hematocrit value, it can define postpartum hemorrhage. but this depends on two factors: the time of the test and the amount of the fluid resuscitation given to. Another consideration is the capacity of each patient to cope with the blood loss. For example, the healthy woman has 30 to 50% in the blood volume. This is in a single term pregnancy, so she's much more tolerant of blood loss than a woman who has, for example, pre-existing anemia or cardiac condition, or sometimes those having dehydration or preeclampsia causing volume contraction. For this reason, the postpartum hemorrhage should be diagnosed with any amount of blood loss that threatens the hemodynamic stability. So postpartum hemorrhage has many potential causes. The most common, as I told you, is the uterine atony, failure of the uterus to contract and retract, of course, following the delivery of the baby. And those having history of postpartum hemorrhage in previous pregnancy, they are at major risk, and we should make every effort to determine its cause. We have several risk factors, starting from the retained placenta, failure to progress during the second stage of labor, for example, those having placenta accreta or genital laceration, those undergoing instrumental delivery, those having large babies, the maternal problem like the hypertensive disorders, the induced labor or the augmented labor with oxytocin, maternal obesity, or those taking serotonin, norepinephrine, reuptake inhibitor, especially in late. Then there is a way for remembering the cause of postpartum hemorrhage. We call it the mnemonic 4T. This stands for the uterine tone, this is tone, then retained placenta, this is tissue, laceration and uterine rupture, this is trauma, then the coagulopathy, this is clotting. So this is the 4 T's or the 4 causes of hemorrhage. This is the cause, maybe the uterine atony, retained tissue, thrombus, or the clotting, the coagulopathy, trauma, combined with the atonic plus traumatic, and drugs. As I told you, the uterine atony and failure of uterine contraction and retraction of the myometrium, there will be rapid and severe hemorrhage and hypovolemic shock, and the overdistension of the uterus, whether absolute or relative. This is a major risk factor for uterine atony. The overdistension of the uterus may be multifetal pregnancy or fetal macrosomia, or mothers having polyhydramnios or fetal abnormality like severe hydrocephalus. If there is structural uterine abnormality, failure of delivery of the placenta, or distension of blood after or before the placental. The poor myometrial contraction results sometimes from fatigue. Maybe this mother has prolonged labor or rapid labor, especially if stimulated. So it results sometimes from inhibition of contraction by drugs, like those having anesthetic agents, the halogenated agents, those having nitrates or non-steroidal anti-inflammatory, those taking magnesium sulfate or beta-synbasomimetic and nifedipine. This is the drugs or drug-induced causes of postpartum. Other causes like placental implantation in the lower uterine segment, the bacterial toxins, hypoxia due to hypoperfusion, or sometimes like you take in abruptio placenta, the covulare uterus, hypothermia due to massive resuscitation or prolonged uterine exteriorization. The grand multipara is not an independent risk factor for the postpartum hemorrhage. The tissue, as I told you, uterine contraction and retraction, of course, lead to detachment and expulsion of the placenta. Complete detachment and expulsion, it permits the continued retraction and occlusion, of course, of the blood vessel. So retention of a portion of the placenta, like if there is subcenturate lobe or accessory lobe, following the delivery of the placenta and there is minimal bleeding, the placenta should be inspected. If there is like fetal vessel crossing to the placental edge, ending in small tear in the membrane, this is retained subcenturate lobe. This is the subcenturate. The placenta is more likely to be retained at extreme preterm gestation, and significant bleeding can occur, and this can be considered in delivery at very early gestation, whether this is spontaneous or induced. The failure of complete separation of the placenta occurs in the placenta accreta and its variant, or we call it the placenta accreta spectrum. There will be significant bleeding from the area where there is normal attachment has occurred and may mark partial complete accreta. There is the entire surface of the placenta is abnormally attached, or sometimes severe invasion. The placenta increta or percreta may not initially cause severe bleeding, may develop when we are doing aggressive effort to remove the placenta. The condition should be considered, especially if the placenta is implanted over a previous uterine scar, especially if it is associated with placenta previa, where it is the different type, the accreta, increta, and percreta. This is the normal attachment. This is the endometrium and the myometrium. This is the accreta. This is the increta. This is increta. This is invasion or percreta. Then all patients with placenta previa should be informed of the risk of severe postpartum hemorrhage, sometimes needing transfusion and hysterectomy. Trauma, this is the genital trauma, occur either spontaneous or through manipulation. I'm using to deliver the baby. Cesarean delivery results in twice the average blood loss of vaginal delivery. Then if I'm doing incision in a poorly contractile lower uterine segment, it heals well but more reliant on suturing, vasospasm, and hemostasis. Uterine rupture, most common in patients who have previous cesarean delivery scars, and any uterus that has undergone procedure resulting either in total or thick partial disruption of the uterine wall should be considered at risk for rupture in a future pregnancy. For example, this is the myomectomy, the uteroplasty for congenital abnormality. If there is ectopic resection, if it is cervical or corneal, there is previous perforation during dilatation of the uterus. During dilatation and curettage, or on taking biopsy, or during, for example, a hysteroscopy or laparoscopy, or even the intrauterine device placement. Then trauma may occur following prolonged or vigorous labor, and if the patient has relative or absolute cephalopelvic disproportion, the uterus stimulated, for example, with oxytocin or prostaglandin, so those having a cephalopelvic disproportion plus stimulation, trauma may occur, and using intrauterine pressure monitoring may lessen this risk. Trauma can occur after manipulation of the fetus, whether extra uterine, and the highest risk is with internal version and extraction of the second twin. However, sometimes external version can lead to rupture of the uterus. Trauma sometimes results secondary to attempt to remove a retained placenta, whether manually or with instrumentation. That's why the uterus should be controlled with an abdominal hand during any. The cervical laceration, common with those delivering with forceps. so the cervix should be inspected following such deliveries. Then assisted vaginal delivery with either forceps or vacuum should never be attempted without the cervix being dilated. This is the different type of laceration, either unilateral, transverse, bilateral, or stellate laceration. Sometimes the cervical laceration may occur. So mothers who have often been unable to resist bearing down before full cervical laceration, you have to inspect the cervix. Sometimes the manual exploration or instrumentation of the uterus may result in cervical tears. Rarely we are doing it purposefully. We incise the cervix at 2 and 10 o'clock to facilitate delivery of the entrapped fetal head during a breech delivery. We call it a dehiscence incision. Vaginal side wall laceration, most common associated with operative vaginal delivery, sometimes occurs spontaneously, especially if there is what's called compound presentation. If, for example, I have the fetal head presenting with the head, the laceration occurs during manipulation. For example, if I'm doing a delivery for a shoulder dystocia. Laceration also occurs in the region overlying the ischial spine. Sometimes the lower vaginal trauma can occur spontaneously, or sometimes during an episiotomy. Spontaneous laceration involves either the posterior fourchette. Sometimes there is trauma to the perirestral and clitoral lesion, and this leads to troublesome hemorrhage. This is problematic area of abnormality in the coagulation system and the platelet can lead to late postpartum hemorrhage, or can exacerbate bleeding from other causes, like, for example, trauma. This is the thrombosis. Abnormality may be pre-existing or acquired. Thrombocytopenia may be pre-existing disease, like the ITP, or acquired secondary to HELLP syndrome, abruptio placentae, or TIC or sepsis. Rarely, sometimes abnormalities or functional abnormalities of the platelets may. The pre-existing abnormality of the clotting system, like the von Willebrand disease or the familial hypofibrinogenemia, may occur and should be considered. How to diagnose if this woman has menorrhagia since minority, if there is family history of bleeding disorder or personal history of notable bruising without injury, or if this patient gives history of bleeding from the oral cavity or GIT without obvious lesion, or epistaxis longer than 10 times, possibly requiring either baking or cautery. This is all we can diagnose this mother has pre-existing abnormality of the clot. The acquired abnormality are more commonly problematic, like the DIC. Then the fibrinogen level, as you all know, markedly elevated during pregnancy. So if the fibrinogen level in the reference range of a non-pregnant state, this should be viewed with suspicious, because sometimes this is secondary to abruptio placentae, DIC from abruptio placenta or HELLP syndrome, or intrauterine fetal death, or amniotic fluid embolism or sepsis. Finally, the dilutional coagulopathy may occur following what's called massive postpartum hemorrhage and resuscitation with excessive amount of crystalloid and baked RBCs. Then prevention of postpartum hemorrhage. Active management of the third stage of labor reduces the incidence and the severity of postpartum hemorrhage. What's the active management of postpartum of the third stage of labor? Active management is a combination of two things: the uterotonic administration, preferably oxytocin, immediately upon delivery of the baby, plus the early cord clamping and the cutting, gentle cord traction with uterine counter traction when the uterus is well contracted, or what we call it the blended Andros maneuver. This is the controlled cord traction with uterine counter. What's the presentation of postpartum hemorrhage? The presentation is most often dramatic. Bleeding may be slower and may still ultimately result in critical loss and shock. More likely to be true of bleeding secondary to retained tissue or trauma. The nursing practice for routine care in the postpartum period should include close observation and documentation of maternal vital signs and condition, vaginal blood loss, and the uterine tone and size. The uterus should be periodically massaged to express any blood clots that accumulated inside the uterus or inside. Usual presentation is one of heavy vaginal bleeding, quickly lead to signs and symptoms of hypovolemic shock. The rapid blood loss reflects the combination of the high uterine blood flow. The most common cause of postpartum hemorrhage is the uterine atony. The blood loss is visually visible at the introitus, especially if the placenta has delivered. Sometimes if the placenta still in situ, significant amount can be retained in the uterus behind the placenta or membrane. So even after the placental delivery, the blood may collect inside an atonic uterus. For this, the uterine size and tone should be monitored throughout the third stage and in the so-called full fourth stage, thus following the delivery of the placenta. How we can do this? You do gentle palpation of the uterine fundus, and if the cause of bleeding is not the uterine atony, the blood loss may be a little bit slower, and the signs and symptoms of hypovolemia may develop over a long time. Bleeding from trauma also may be concealed, sometimes in hematoma, retroperitoneal hematoma, broad ligamentary hematoma, or lower genital tract hematoma, or sometimes inside cavity. The two important facts worth bearing in mind. The first is the caregivers consistently underestimate the visual blood loss by as much as 50%. You know that the volume of any clotted blood represents only half of the blood volume required to form the clot. And the second is that most women giving birth healthy and they can compensate well for the blood loss. Thus, combined with the fact that the common birthing position is some variant of semi-recumbent position with the legs elevated, so the symptoms of hypovolemia may not develop until a very large amount of blood volume has been lost. So rapid recognition and diagnosis of postpartum hemorrhage, this is very essential for successful management. The risk state of measure and the diagnosis and treatment of the underlying cause must be quickly before sequelae of any hypovolemia, and the major factor in the adverse outcome associated with severe hemorrhage is delay in initiating a. What are the lab studies you are going to do? Number one is the complete blood picture, because this, according to the blood picture, it can alert me to patient with anemia, so I can do intervention early to improve the hemoglobin level. And if it is below 10 to 10.5, it's associated with adverse pregnancy outcome, and sometimes the rare patient with thrombocytopenia can be identified. So women admitted to the labor and delivery unit should have a complete blood count performed, if not performed recently, and those having antepartum hemorrhage or experiencing antepartum hemorrhage, complete blood count. I should do blood typing and antibody screening in the antenatal period, and the time frame from I'm requesting the blood products to their availability should be known. In a patient with high risk, I should do cross-matching of 2 to 6 units of blood before delivery to make it stand by. Then example, those having previous severe postpartum hemorrhage, those having placenta previa, possible accreta, multiple previous cesarean deliveries, those having coagulation disorders or severe thrombocytopenia. I should do cross-matching for at least 2 to 6 units of. So once I diagnose postpartum hemorrhage, CBC and baseline coagulation study, I should do it. Then the hemoglobin value initially does not reflect the amount of blood loss. I told you to cross-match 4 to 6 and sometimes 2 to 6 units of bagged RBCs. And you should notify the blood bank that you may need additional blood products. Initial coagulation study, usually within reference range. However, abnormalities may be noted. Most common when postpartum hemorrhage is preceded by, for example, abruption placenta, HELLP syndrome, intrauterine fetal death, embolic event, or fatty liver of pregnancy. Or then if the INR or the activated partial thromboplastin time are elevated, then you do fibrinogen, thrombin time, D-dimers, and blood film. And in late pregnancy, as I told you, the fibrinogen is 2 to 3 times the upper reference range. So if I find it within the non-pregnant reference range, this should be viewed with caution because this suggests coagulation. Then the onset of postpartum hemorrhage is generally rapid. So if I'm doing proper diagnosis and treatment, resolution occurs even before further lab work or imaging. The assessment of uterine tone and size is accomplished using a hand resting on the fundus of the uterus, and you palpate the anterior wall of the uterus. If I find a bogey uterus with either heavy vaginal bleeding or if the uterine is increasing, this is equal to the diagnosis of uterine atony. If the placenta has been delivered, you inspect findings suggest whether there is portion of it have been retained inside the uterus. If it is undelivered or retained the clot or placental fragment distending the uterus, and there is persistent bleeding despite appropriate ongoing treatment, then you should do manual removal and manual exploration and removal undertaken, and this simultaneously by emptying the uterus, so you permit the uterus to contract, aiding the diagnosis sometimes of aiding in the diagnosis of placenta accreta and uterine ridge. For the laceration, they can be palpated at the time of the exploration. Then the imaging study, you can do a bedside ultrasound. You can find blood clots or retain the products inside the uterus. However, the treatment includes manual exploration. This renders ultrasound redundant in the acute setting when treatment must not be delayed. For example, the antenatal ultrasound is indispensable for detecting the high-risk patient who are at risk factor for postpartum hemorrhage, like those having placenta previa before. They are increasingly sensitive and specific in the diagnosis of placenta accreta. This is the 4 T's of postpartum hemorrhage: tone, the atony, the trauma, the laceration or the hematoma or the inversion or the rupture, tissue like the retained placenta or the invasive placenta, the coagulopathy. Sometimes the Asian insanity, the anemic patient, those induced labor, those who are obese, the BMI more than 35, prolonged labor and age. This is another cause for medical therapy. The treatment has 2 major components, as I told you beforehand: resuscitation and management of obstetric hemorrhage, identification and management of the underlying cause. Remember, for successful management, you have to do both components simultaneously and systematically. The management of obstetric hemorrhage Those patients require aggressive measures to restore and maintain their circulating blood volume and thereby the perfusion pressure structures. The diagnosis is established by observing the amount of bleeding and the patient clinical status. The amount of blood loss and the patient consciousness or level of consciousness and vital signs should be assessed continuously. Once you made the diagnosis, you immediately notify your appropriate staff members. The underlying cause of bleeding to some degree dictate at least you have a minimum of one obstetrician and one anesthetist is. You have to be with a skilled midwife or nurse. This is indispensable. Then notify the blood transfusion service because you want availability of blood products. Again, as in the cardiac arrest, you have to designate an experienced person to document each and every critical information and time, then ensure the availability, of course, of an operating theater. Fluid resuscitation, those having obstetric hemorrhage, sometimes you can give it the fluid resuscitation. Possible reason, the blood loss being generally underestimated both in volume and rapidity, and women initially compensating for loss because of the good general condition and the hypervolemia of pregnancy, concerned that over resuscitation lead to pulmonary edema, and the dynamics of fluid shift in the body, maybe sometimes you cannot properly appreciate it. That's why fluid resuscitation in obstetric hemorrhage is sometimes overly conserved. You can start with raising the legs of the patient. This will improve the venous return. This is consistent with the positioning used to diagnose and treat the underlying cause. You give oxygen and you obtain IV intravenous access, and all the line, of course started on the labor ward for other reason, must be placed with cannula sufficient gauge if postpartum hemorrhage develop. For example, the 14 gauge intravenous line delivered or infused twice as much fluid as the 18 gauge intravenous line over the same time. During labor, place at least one intravenous line in women at risk for postpartum hemorrhage. Consider the second line was at very high risk. This is the orange one. This is better than the green one. This is the 14 and this is the 18. Then you perform initial resuscitation with large volume of crystalloid like the normal saline or the LR, the lactated ringer, through peripheral intravenous sites. The central venous access sometimes not required, except, for example, in patient with severe postpartum hemorrhage. Then draw blood for baseline measurements at this time. Remember that if your patient loses 1 liter of blood, she requires replacement with at least 4 to 5 liters of crystalloid. Why? Because most of this infused fluid is not retained into the intravascular space. Instead, they will shift to the interstitial space, especially if you are using oxytocin. This will result in peripheral edema in the first few days following postpartum hemorrhage. Then, if there is postpartum hemorrhage of at least 1.5 liters and your patient is healthy pregnant woman, they can be managed only with crystalloid infusion if the cause is arrested. The blood loss in excess of this usually require the transfusion of RBCs. Then the blood transfusion, if the blood loss is ongoing and in excess of 2 liters, or if your patient clinical status reflects shock despite aggressive resuscitation, you should order blood transfusion. You give barred and bagged RBCs initially, then other blood component if indicated. You In postpartum hemorrhage, sometimes we can give uncross-matched ABO and RH compatible blood. It's usually available because blood group and antibody has already been performed. You do full cross-matched blood available for transfusion, whether the risk of transfusion, of course, is the transfusion reaction, the infection, or the development of atypical antibodies. Risk of hypothermia is minimized by the use of blood warmers. Sometimes there is dilutional coagulopathy. Sometimes there is hyperkalemia and acidosis if you are using stored blood. Seldom clinically important. You should monitor the electrolyte and acid-base balance, and sometimes there is hypocalcemia due to citrate intoxication. What's the response to resuscitation? You have to pay very close attention to the patient conscious level, pulse, blood pressure, urine output during the management of this massive hemorrhage. The urine output of 30 ml per hour or more indicate that there is adequate renal perfusion. You closely monitor the blood count, the coagulation, the blood gas value, in addition to the acid-base status. For evaluating the tissue perfusion and the oxygen saturation, use the pulse oximetry, then frequent auscultation of the lung base to exclude pulmonary edema or the development of the RDS, the adult respiratory distress syndrome. Those who have ingoing bleeding and critical condition, you should place a central venous line. This may be helpful. This is the management of postpartum hemorrhage according to the cause. Determine the cause. If it is stone, you go for oxytocin medication or carboprost, misoprostol, ergonovine or ergometrine. If there is trauma, then suture the laceration. There is expanding hematoma, draining and replace the inverted uterus. If there is retained placental tissue, inspect the placenta, explore the uterus, then you do manual removal of the placenta and the curettage. If the thrombin, the blood not clotting, you observe the clotting, check coagulation, replace the factor and give fresh frozen blood. Then the management of underlying cause of postpartum hemorrhage. The uterine atony. Oxytocin is the drug of choice for post-prophylaxis and treatment of postpartum hemorrhage. The oxytocin if the uterus is not well contracted, you start with vigorous massage and therapeutic oxytocin. It can be given as 5-unit intravenous bolus, or you can give it intravenously 20 units in 1 liter of normal saline as fast as possible. Or you can give it 10 units intramyometrial, sometimes with a spinal needle if there is no immediate intravenous access. This is the oxytocin. You should empty the uterus because this facilitates the uterine contraction, and subsequent therapeutic maneuvers can be done easily. Then you should wear a waterproof gown. Then elbow length gloves, eye protection during the management. Sterile technique, of course. This is the uterus remain atonic. You do bimanual massage. You put hand on the fundus and the second hand you place it anterior to the cervix in the vagina. Prepare the perineum and the vagina. Vaginal hand may be covered with Providil and or lubricant to allow it to enter the vagina with less difficulty. You should take care to minimize causing or worsening any trauma in the lower. Then trauma to the vaginal side wall and cervix, you can palpate it with your hand gently introduced in the vagina. You can evacuate blood clots from the lower uterine segments, from the cervix, from the vagina. Of course, you will put the vaginal hand in the anterior fornix and the abdominal hand on the posterior aspect of the fundus. You raise the uterus from the pelvis, compressed between the two hands. The compression will of course expand the blood clots and decrease the bleeding. Then massage the uterus between the hands, aid in promoting and sustaining the. Use other uterotonic agents if the uterus is still atonic, despite the oxytocin administration and the bimanual massage. The traditional second line is the ergonovine or ergotrate, given as initial dose of 100 or 125 microgram IV or intramyometrial, or 200 or 250 microgram intramuscular. The maximum dose is 1.5 milligram, and the relative contraindication. Sometimes they give intramuscular carboprost as a second line. The recommended dose is 250 microgram IM or intramyometrial. Do not exceed 2 grams, meaning the 8 doses. The carboprost, it's 80 to 90% effective in stopping the postpartum hemorrhage in cases refractory to either oxytocin or ergonovine. Misoprostol again can be given in the treatment of postpartum hemorrhage. This is the third line agent in the management of postpartum. This is the carpotocin or the long-acting oxytocin. In market we call it partum. Then if there is retained tissue of the uterus continues to contract poorly, or it relaxes when bimanual compression and massage are stopped, so perform manual exploration. If the placenta not yet delivered, now you have to deliver it with cord traction and uterine counter traction, and you have to take care that there is risk of uterine inversion, so perform the manual removal if the placenta is not easily delivered or the cord is. This is the separation of the placenta from the uterus with a sweeping motion. Then the placenta is separated. You curl your palm around the bulk of it. Then continue to grasp the placenta as you remove it from the uterus. Surgical management is necessary if the uterus does not remain contracted and there is persistent bleeding despite all efforts done. Sometimes they can do packing of the uterus until the operating room is ready, or if surgery is not an immediate available option, they tightly pack the uterus and the vagina with continuous layer 2 or 4 inch gauze. Of course, under direct visualization, they use a speculum and or retractor or a purpose-built uterine packer, just packing the uterus until the operator is ready. Then intrauterine catheter for tamponade have been used. We have one device, we call it the Bakri tamponade balloon. This is a balloon, a tamponade. This is like tamponade balloon to control bleeding from an atonic uterus. Sometimes in a low resource setting they use condom or surgical glove, and successfully it comes. If there is genital tract trauma, I should manage accordingly, of course suturing. If there is coagulopathy, if I do manual exploration and it does exclude uterine rupture or retained placental fragment, then bleeding from a well-contracted uterus, most commonly due to defect in hemostasis, then you proceed with blood product replacement in order to correct abnormality of surgical therapy. Ongoing bleeding secondary to unresponsive atonic uterus, ruptured uterus, or there is large laceration in the cervix extending into the uterus does require surgical intervention. For example, we can do when the medical management is unsuccessful, arterial embolization, balloon tamponade like the Bakri balloon, uterine compression suture, or internal iliac artery ligation or uterine devascularization. Of course, the balloon tamponade, this is the least invasive and most rapid approach, and maybe logically the first step. This is the different suturing technique to control the bleeding. And this is ligation of the uterine artery and uterovarian artery. This is one of the internal ear. And the last step, we can do hysterectomy for this patient, the subtotal. The complication of postpartum hemorrhage, of course, the maternal mortality, as I told you in the beginning, it does represent 34% of maternal mortality rate in Egypt. The hemorrhagic shock due to excessive and rapid blood loss and possible DIC, acute renal failure secondary to hypovolemic shock, puerperal sepsis secondary to the low immunity, and of course the manipulation and the retained tissues. Sheehan syndrome if there is hypopituitarism leading to secondary amenorrhea due to the volemic shock. I thank you for your time and attention. I'm Dr. Manal Hamdy.